Good evening, everyone, and thank you for joining me for this webinar about all things chronic pain related. Tonight, we're going to talk about how to consider chronic pain from a new perspective, how to reframe the experience of dealing with chronic pain, and hopefully give you some takeaways and some changes that you can make today to help you get yourself out of pain. So this webinar is actually in anticipation of my upcoming book called Pain Proof, which you'll be hearing a lot about over the next couple months. So without further ado, let's get started. So for those of you who don't know me, my name is Dr. Robert Kachko. I'm a naturopathic physician and a licensed acupuncturist. I practice at Inner Source Health right in the middle of Manhattan. And my practice really historically is focused on some combination of chronic pain and cardiometabolic risk reduction. So you may have joined some of my previous webinars about cardiometabolic risk reduction. But as we'll talk about in a few moments, chronic pain is really something that we've been seeing a lot more of in the practice, unfortunately, and it's something that all of our tools and our naturopathic toolkit, which we'll be talking about as well, can really be useful for. In addition to my practice, I've actually spent the last couple of years working on a healthcare technology startup called Tribe RX, and that really focuses on much of what we're going to be talking about today, some of the psychosocial components of helping people deal with chronic pain. And our focus really has been on helping individuals with chronic pain and even opioid use disorder to feel better supported, better heard, and better understood. And a little bit later in the webinar, we will talk about some of the core components of that psychosocial program and just as importantly, why that matters, how that contributes to someone dealing with chronic pain. And then finally, I do a lot of work in the realm of integrative and naturopathic medicine. I'm incoming president for the American Association of Naturopathic Physicians. I've had the good fortune of sitting on the board for the AANP for the last, almost 5 years now. And previously, I sat on the board for the New York Association of Naturopathic Physicians, really working pretty hard to get licensure for NDs in New York, which been working on for a while, and some docs have been working on for much longer than myself. But, we're always hopeful, and our goal really is to make sure that naturopathic medicine is accessible and affordable to everyone in the state of New York, but also nationally when it comes to the AANP. So a little bit about our practice. Inner Source Health has been around, I believe, since about 2002. We've got two main locations right now. We've got our office in Manhattan, New York City, right across from Penn Station at 30th and 7th. That's actually where I see all of my patients. And we've got another office out in Huntington, Long Island. We've got some great docs in both locations. So if you aren't currently a patient of Inner Source Health, I do encourage you to reach out. The reason we have so many doctors and so many different providers is that we want to make sure that we're offering experts for whatever condition it is that you're coming in with. So at Inner Source Health, we've really taken it upon ourselves to make sure that we've got those experts on board. And of course, we refer out when necessary. So before we talk about chronic pain and some of the things that we can do about pain, I think it's worth understanding why it is that I even care about this, why it is that our healthcare system should care about this. I suspect that if you're listening to this webinar, you care about it because you're dealing with chronic pain for yourself, or perhaps for a loved one, and you're looking for some pretty effective tools to help you rid yourself of that pain. It turns out that you are not alone if you're dealing with chronic pain. Based on most estimates, about 100 million Americans deal with regular chronic pain. And according to the Centers for Disease Control, up to 20 million Americans deal with what they call high-impact chronic pain. That means it's impacting them on a day-to-day basis, impacting quality of life, the ability to work, things like sleep, things like happiness and stress function. And so this is a huge problem for our country. And so on a macro level, we need to make sure that we're offering comprehensive, and I'm going to be using this word pretty often, biopsychosocial treatment approaches. But what I really saw in my own practice, where I have the luxury of spending a lot of time with my patients, I saw that people really needed more support than they were getting from the healthcare system at large. Chronic pain in and of itself is a very isolating experience. It sometimes can feel very much like you're alone. And so it became pretty clear to me that there was a lot of confusion out there as to what works and what doesn't for pain. There was also a lot of desire on behalf of patients coming in to feel better understood and to feel heard. And one of the challenges is especially with long-term chronic pain, is very often our healthcare system can't really offer much in the way of answers as to why we're feeling this way. And that was a common theme that I was seeing for the patients that were coming in to see me. And luckily, the tools that we have at our disposal at InnerSource Health, and the tools that I've cultivated and all the trainings that I've done, I was seeing results over and over. People are getting better. Not everyone, and everyone's story is very different, of course. But very consistently seeing improvement, and a lot of that improvement required some of the reframing that we're going to be talking about. But just the same, some of our techniques can offer pretty quick and effective solutions as well. That's why I care about this. That's why I'm writing the book, and that's why we want to make sure that this information gets out to everyone, because it's a struggle, and it's something that we feel very well equipped to handle at our practice. And so the question actually becomes, why pain proof? It's kind of a weird play on words a little bit. And actually I got the idea for the title pain proof in a rather tangential way. Before I started naturopathic medical school, I had read a book called Anti-Cancer. And Anti-Cancer was a book by a PhD researcher, actually, who ended up, while doing research, discovering, based on a scan, because a patient didn't show up the day that he was supposed to for the research, based on a scan of his own brain, he put himself in as a subject for this study. They discovered a brain tumor, and so he took it upon himself to figure out what it was that he could do, in addition to conventional treatments, to create a body that was resistant to cancer or resilient to cancer. And that's a theme we're going to be coming back to over and over during this talk. And so what was really interesting to me was this notion that we can build up a resilience to any kind of chronic disease that we have, understanding that our conditions are always a combination of our genetics and our lifestyle choices. I've always had an issue with this word anti, because anti almost makes it feel like we're fighting against our bodies, and that's not really the goal. Anti-inflammatories, anti-nausea medications, they have a role to play, of course, but what's also important is that we honor the physiologic and the biochemical processes that our bodies go through. And so this idea that we can make ourselves pain-proof is one that really resonates with me, and as I've been working with a lot of my patients dealing with pain, it really seems to resonate with them. It kind of clicks, and it's a sticky idea. And so that's where the title of the book and also this webinar came about. And to put that into a little bit more concrete terms, if you look at the screen right now, you're seeing an image of two different knees. And on the left is what we would imagine would be a knee with really good cartilage, really good joint spacing there, where the two bones that meet in the knee aren't actually touching each other. And generally speaking, we've always believed that the more cartilage someone has, the healthier they are and the less likely they are to be in pain. Again, this is our general concept that we've had for a long time. The image on the right is very different. It's what some people would call a knee that looks bone on bone. Part of the challenge with this concept, though, is we would always expect that a person with the knee on the right here on the screen would be in constant agonizing pain. And the person on the left is unlikely to have pain at all. The challenge with that idea is that our bodies are far too complex to really only pay attention to these structural components that we're seeing on imaging, things like X-rays and MRIs. And it turns out, much to my surprise when I first read this research years ago, it turns out that people with this bone-on-bone, knee on the right, quote-unquote damaged knees, tended to actually feel no pain at all about 40% of the time. And that goes against all the conventional wisdom around what the imaging should look like in a knee that hurts. People on the left side with quote-unquote healthy-looking knees that look like they have perfect joint spacing, Well, about 15% of the time they can still experience some pretty severe pain if some of the other conditions around this physical part of their structure are not appropriate. And those conditions, the factors that contribute to people on the right side of this picture having no pain at all, having more resilience to pain, and then vice versa, people on the left side having pain in spite of normal structure. Those are the factors we're going to be talking about today when it comes to pain-proofing ourselves and our loved ones. And so this comes from this idea of the structural model. The biomechanical model is another way to describe it. The structural model is what we've really been used to. It's, if you go to an orthopedic surgeon, if you go to a neurologist with your pain, if you go to a chiropractor and physical therapy, we often really consider this structural model, and we really want to make sure that we can pinpoint and find why it is that someone is experiencing their discomfort. And put another way, that often is translated into looking for the cause. The challenge with this model is that, frankly, it has failed us. Very often we use imaging to decide on what treatments are most appropriate. And one of the most common treatments that we would use imaging to decide are back surgeries. And the data for back surgeries is actually pretty staggeringly poor. What we find is that about a third of people who get back surgery for a disc issue, a disc herniation issue, which we're going to talk about in a second, about a third of people get better. About a third of people end up staying the same, and fully 1/3 of people actually feel worse after their surgery. And you go back into the imaging and you see that the structural issue that was there has actually been repaired. The surgeon did a really great job, but this person is still in pain. And so this points out the fact that the model that we've been using for so long, this structural model, is far too simplistic. Our bodies are far too complex. And frankly, my job would be easier if we can just look at structure and understand why someone is experiencing pain. Unfortunately, that's not the case. And so we have to look deeper and dig deeper. And so I mentioned some of the paradoxes around the knee imaging. Well, we actually see that a lot more with disc issues and MRIs of spinal discs. And so most often we're told that if we have a herniation of a disc, if our disc is bulging and it's impinging on the nerve, that's likely to cause pain. The classic example is it's likely to cause something like sciatica, which is an impingement of the sciatic nerve running down our leg. And that's why your doctor will always ask you, well, if you have back pain, is it radiating into your leg at all? The challenge with that idea, again, if you're picking up on my theme here, is that if you show 100 radiologists a couple of thousand images of people's backs, they couldn't predict based on the imaging who actually experiences pain and who doesn't. If we quote unquote blind those radiologists to who's feeling a certain way, we cannot predict based on their imaging alone whether they're going to be in pain or not. And this really came out in an especially strong way in a study that was published in April of 2015, so a couple of years ago now, where they looked at people specifically without pain, and they followed people, and they looked at people in their 20s and the 30s and 40s, all the way up to age 80, and they did imaging on those people. And the radiologists didn't know whether the people had pain or not, but everyone in this study was not experiencing pain at the moment of the study and had not had a significant history of any kind of chronic back pain or any kind of radiation that we would expect from a disc bulge. And what we found was that actually degeneration of the disc and bulging of the disc or herniation, and even something called spondylolisthesis, which is slippage of our vertebrae one over the other, which even sounds like a painful idea. It's actually a pretty common phenomenon, and it does go up with age. And so you see on here, as people got older, their likelihood of having herniated discs was pretty high. And, at age 50, where we still consider people very robust and healthy and not necessarily predisposed to any kind of chronic disease, by age 50 in this fairly large study, about 80% of people actually had what was shown on imaging as degeneration of their discs, that their discs were actually breaking down. 60% of people had herniations, but no pain at all. And so this whole structural model where we say there's a disc, and it means that we have to be in pain, kind of gets flipped on its head. And again, if it was so simple, people would be better, and 1/3 of people wouldn't be feeling worse after back surgery if we actually figured out that structural solution. And now the challenge with this model that we've had alongside this, what I would call failed structural approach, is also the challenge that our healthcare system for many decades has been sort of paternalistic, where we go to our doctor and we expect all of our healing to come from them. And this, what I would call, is a fear-based model. And a fear-based model certainly does not contribute to better outcomes. And the reason I've got a jelly donut there is that within that structural model, we're sort of made to believe that we've got these heavy bones, these vertebrae, that are divided between these soft, malleable, and easily damaged discs. And if the inside of that disc pops out, then we're going to have pain, we're going to have nerve pain, and it's something that we won't really be able to fix unless we go get surgery or unless we get some invasive treatment. Otherwise, either a pain pump attached or taking medications that in some ways can be pretty addictive. And so this idea that we are fragile and that our bodies are broken when we're dealing with pain and need to be fixed is a really challenging idea. It instantly disempowers each patient who comes in to see that doctor. It takes away their sense of agency. And this idea that the fix for whatever ails us has to come from our doctor really just perpetuates that issue. And then finally, this fear-based model takes into account this idea that we can't pain-proof ourselves, that there are not lifestyle things that we can do, that there are not choices that we can make or mindsets that we can take that actually will reverse how we're feeling. And so again, this idea that we can't help ourselves, all of the fix has to come from our doctor, is independently proven to make us feel worse across the board, across most chronic diseases, but especially true when it comes to chronic pain because of some of the brain mechanisms that actually go on when we buy into that approach. On the flip side is a hope-based model. And some of the key features of a model based in hope, one that tells you, you know what, you can recover, but within the confines of a different understanding of what pain means for you. Those types of treatments and those types of care plans really treat you as a person and not just a patient. They have to understand how your discomfort fits into the ecology of your life. Those treatments must also be very comprehensive. We can't just look at this structural model, as I keep saying, and expect to solve the whole challenge when it comes to chronic pain, which may be very different from acute pain. And we'll get into that in a second. And put another way, it has to take the perspective of both how the body and the brain are perceiving our pain. Number three, a hope-based model of care has to involve you. You need to understand that you are at the center, and any healing that will occur will be the result of what you and your body are able to do as supported by your healthcare team. I'm not saying that your healthcare team is not important here. It's very much not true. But what is true is if you don't feel empowered to take charge of your health, their job becomes much more difficult. Number four, this type of treatment approach has to acknowledge what's possible. It has to take stock of what you are able to do. Very often when people deal with chronic pain, and 4 and 5 are very similar in this regard, we tend to sort of mourn ourselves and mourn the selves that we've lost. And that it becomes a real challenge. And again, independently verified in research to show that once we feel like we've lost ourselves and we don't put value into the things that we still can do, it actually makes the pain relief much more difficult. And it makes the job of the doctor much more difficult. And then finally, a hope-based model of care has to allow you to feel both heard, understood, and supported. I guess that's 3 things, but it's just that important. It has to acknowledge the fact that if you're dealing with pain, you are not alone when you're dealing with your pain. I mentioned at the beginning of this webinar, 100 million Americans deal with pain, 20 million Americans deal with high-impact chronic pain. At the same time, it can often feel when dealing with debilitating conditions like this that you're alone in this condition. Your friends don't understand what you're going through. Your family can't relate, though they really want to. And so it does feel alone. It can be pretty isolating. And as we'll talk about in a little bit, that feeling of isolation can actually perpetuate how you're feeling altogether. And so the way we've always considered this is that our pain is at the center, and we've got all these tools. We've got surgery, physical therapy, exercise, different injections or medications. If we're lucky, someone's going to talk to us about nutrition and sleep. and the role of psychosocial support. And our pain is at the center. And really, for a hope-based model, we have to flip that script. You, as a totality, as a whole person, is at the center, and you're allowing all of these other modalities to be a part of your healing journey, but you're not allowing them to be done unto you. It's something that you are at the center of, and it's a really important concept, and it's something that for most of the patients who come in to see me who want to deal with this, we start with these conversations because it makes everything else more effective. Now, I mentioned earlier that the structural model might actually be a pretty good model for acute pain. What we've done really in the last couple of decades is taken what we see works for acute pain if someone breaks their arm, for example, and we've expanded it into chronic pain care. And one thing that can happen is this idea of pain chronification. There are certain factors, certain mindsets, and certain factors around the ecology of our lives that contribute to acute pain turning into chronic pain. And usually that happens at around the 12-week point. What we find is that in the first 3 months, really, people who are dealing with acute pain, we expect that there's still tissue healing that needs to happen. There's ongoing healing. Again, if we take that example of the broken arm, that bone needs to mend itself. It needs to heal. It needs rest. Sometimes it needs ice. Sometimes it needs heat. And, we're not really talking about acute pain here, but the understanding that tissue healing is ongoing is important. When it comes to chronic pain, and of course, for every condition, the length of time that takes is going to be different. But once you go past 12 weeks as a pretty decent average, the tissue healing that needed to happen has likely already taken place. The challenge with that is our doctors are telling us, or our healthcare team is telling us that, that bone has healed, that knee has healed, whatever it is that we're trying to quote unquote fix, but we still feel the same or sometimes worse. And maybe the quality of the pain has changed, but it's still with us and it's still disrupting our lives. And that's where some of the techniques that we're going to get into in a moment are really central and really important. This idea that we have to address chronic pain very differently than we do acute pain. And just the same pain medications, a lot of the common pain relieving medications that we're used to are quite useful for acute pain. They're a little bit less useful for chronic pain because what they don't accomplish is sending the right signals to the brain and allowing the brain to send the right signals to the body. We'll be getting into that in a moment, to be most effective. And there are other commonalities and other differences between acute and chronic pain. For example, in terms of acute pain, you probably want to rest and give your body a chance to recover. When it comes to chronic pain, one of the paradoxes is, we feel back pain, and every time we move a certain way, we expect our back to hurt more. So we stop moving altogether, and very often we lay in bed, and very often we don't leave our bedrooms. And the paradox there is that actually makes, unfortunately, our pain worse. And so our body is sending us a signal that something is dangerous, that something is unsafe for us, and that we need to change our activity around that. And very often we can get into a bad habit that actually perpetuates the pain and makes it worse. And so that's a very normal response. That's a normal mechanism. There was acute pain. There was some kind of tissue injury, or maybe some kind of inflammation going on from an immune-mediated disease like autoimmune rheumatoid arthritis, for example. And that sent a signal to our brain that there was danger and that something needed to be done. However, once that process has been ongoing for long enough, that danger signal just simply never got turned off. And so what we need to do in pain-proofing ourselves is learn how to turn off that pain signal. In order to do so from a chronic pain perspective, this requires what's called a biopsychosocial approach. And so biopsychosocial, we really have to break down into 3 sections. Bio, which is biological, biomedical, is the type of care that we're getting from our healthcare team. Psychological, which is our perspective and our mindset around what it is that we're experiencing. And social, which quite literally is the ecology of our lives, the ecosystem around which our pain is occurring, and very much in a big way that involves our level of social support and whether or not we're getting enough, and again, whether we feel connected and heard and understood. So we won't get too deep into the weeds around some of the physiology of pain and actually what happens when we experience something like back pain. But suffice it to say, there's either an injury or some initial cause, and there's a signal that's sent from our area where we feel the pain, whether that's, again, our back or our knee, and it goes up to our brain. And one of the things that's really important to understand is that our backs don't actually experience pain. Our knees don't experience pain. Our ankles don't experience pain. Our brains help us process and experience that situation. And so even though it feels like the pain is in our back, the pain is actually a signal that the body is translating into a different language, and it's read by the brain. And so the way our brain reads that signal is a really important part of this process. Now, very often people can hear that and can hear a similar but very different idea that pain is only in the brain. This is another disempowering idea. Sometimes you'll go to your doctor and they'll tell you, look, there's nothing wrong in your blood work, your imaging is fine, and they make you feel like either you're making it up or the pain is all in your brain. And then sometimes they'll even go so far as to prescribe you an antidepressant. Well, antidepressants are actually effective for some forms of pain, but that's not really getting to the root cause of what's happening here. It's not that you're depressed and you're in pain and you're making it up. It's that the brain is now amplified to experience pain happening in the body in a very different way. Put another way, the brain is now sensitized to experience pain that's happening in the body. And so if we take what's called a bottom-up approach, we really want to make sure that we're healing the local tissue. But what we also have to do is take a top-down approach. And so on the left here is the part of the brain, the somatosensory cortex. This little weird-looking guy is actually called the homunculus. And it's the different parts of our brain that actually are related to different parts of our body when we experience pain. And so if someone has feels a certain sensation in their hands, and our hands have a lot of nerves, and so that's why the hand is drawn bigger here. And same thing with the lips, whereas our back and our trunk takes up less space because we don't have as fine of an understanding of the nerves going on there. When we experience pain in our back, it actually shoots up here and our brain says, aha, okay, I understand, it's pain in the back. And so I need to do something about that. And very often that'll mean don't move, or change your body position, or stop doing whatever activity was that brought that on. And so if we take a top-down approach, our interest becomes not so much about the back pain that we saw on this previous slide, and not so much the local area of discomfort, though that is important. This bottom-up approach is important. We have to understand what it is that the brain can do to send a signal back down to that part of the body, back down to the spinal cord, where this is all relayed, to say, you know what? I'm aware of this discomfort. I've assessed the situation. It's no longer dangerous. We don't need to set off these alarm systems that this person is now feeling as pain. When it comes to chronic pain, these top-down signals are not very effective. And so a pain-proof mindset and a pain-proof body has better communication between the brain and the body, and then vice versa. So for anyone to feel truly well when it comes to dealing with their pain, we have to take both a top-down and a bottom-up approach. And I would venture to say this top-down approach either never happens and is never discussed in treatment, or is discussed only in isolation. So sometimes people will get a referral to a pain psychologist. And unfortunately, that perpetuates this idea again, and people hear a referral to a psychologist and they're being told almost that your pain isn't real, it's just in your head, it's just being made up. That's not the case. What does make sense, though, is that we address the physical body where we feel that discomfort, but we also address this top-down signal approach from one part of the brain to the other. I already mentioned this idea. Our brains, when it comes to chronic pain, are sensitized to experience the world as more dangerous. One example that I think I can give is in terms of movement. And so if someone has neck pain, for example, and every time they rotate their head to the left, it sends a signal to the brain that, hey, this is dangerous for me because it hurts. And that signal goes top down and bottom up, and it continues to be reinforced day after day until finally the brain says, well, you know what? We're smarter than this. If we know that it takes us maybe 20 degrees of rotation to the left to experience pain, well, I'm going to send that pain signal at around 18 or 19 degrees of rotation before we're actually even in the position where we're experiencing pain. And so our brain becomes sensitized. And this homunculus, say it's neck pain, and the person is experiencing it over here in the neck, well, that area actually literally grows in size at the expense of other aspects of our brain, whether it's our vision or our hearing or some of our emotional centers. The part of the brain that perceives the area that we are sensitized to experience as painful actually grows in size. And that's based on a concept called neuroplasticity, which we're going to get into in just a few moments. So there's a paradox, and I've mentioned this idea that pain is never just in the brain, and it's never just something we're making up. But we do have to acknowledge two really core ideas here if we're going to expect to feel better on our journey to recover from chronic pain. The first is that much like with some of the mental health conditions that we deal with, especially anxiety, one of the worst things we can do to help ourselves feel better, paradoxically, is actually to just wish the pain away, to continue to focus on it and to continue to wish it away and say, I would feel better when this pain was 100% reduced. That mindset has been shown through independent research actually just to make our pain worse. And so how deflating is that, right? The thing we want to get rid of, and the very act of trying to get rid of it actually just makes it worse and it becomes a vicious cycle. And that's really hard to deal with. And then number two is we really do better. And I see this with my patients nearly every day. We do better when we focus on quality of life as opposed to full and complete elimination of pain. And these are some concepts that we're going to talk about based in what's called ACT or ACT or acceptance and commitment therapy that really have been shown to be quite effective alongside these bottom-up approaches to help people feel physically better. So there's this idea that when we looked at the image of the knee in the beginning, what is it about those 40% of people who have bone-on-bone pain, bone-on-bone knees and almost no cartilage there, but don't experience very much pain? And then this begs the question, is there something called a pain personality? Is there something about either our genetics or our upbringing or our experiences that primes us to be more likely to deal with chronic long-term pain? And I would say, based on the research, that there really is, and there are three key themes that someone who's more likely to experience pain will deal with. And those are low self-efficacy, feeling like it's impossible to take charge of your own health and it's impossible to make the changes you need to get yourself out of pain. Number two is this idea that when someone who has a high pain personality experiences their pain, they put a different meaning around it, and they use a word that's often used in the literature called catastrophizing. Or they don't actually say that word, of course, but what they do is they catastrophize their pain. For example, well, my back hurts. This means I'll never be able to work again. How am I going to support my family? This is the end of me. That mindset, though it's completely natural and it's a very normal response to dealing with long-term pain, there's no judgment here, but that mindset in and of itself actually makes pain worse and makes it more difficult to recover from. And then finally, people who tend to be what's called hypervigilant to the outside world. Hypervigilance really is sort of always being on, always being primed, and this feeling like the world is a little bit more dangerous than maybe other people perceive it to be. And so a pain-proof mindset takes all of these components, these three components, and again, without judgment, helps to reframe them through education, through an understanding that, for example, between the catastrophizing issue and the hypervigilance issue, through an understanding that, well, even though we're feeling pain now, doesn't mean it'll continue forever. And just as importantly, even though we're feeling pain now, it doesn't mean that we're continually harming ourselves. So it is possible to make some of these changes that someone with high self-efficacy might undertake to feel better. And so a pain-proof mindset understands these things, puts them into the right context of our lives, and initiates treatment around that. And then on the flip side, there are mindsets in parallel to those that we saw in the previous slide that directly have been shown to reduce pain. Someone who has high trust in themselves and their ability to self-heal tends to feel less pain. People with a clear and very thorough long-term understanding of what it means to deal with long-term pain with some of this education on board tend to do better. And people who feel safer in the world, which is not something you can just tell someone, hey, you should go feel safer in the world, but there are some proven techniques to cultivate that mindset, tend to have less pain as well. And so I think it's worth pausing here and taking an understanding that when people deal with chronic pain and they're told that they're never going to get better unless they get surgery or some other invasive treatment, not only does that disempower them and make them feel worse, but it also quite literally changes their brains to continue to feel worse into the future. And we've had this concept that's been disproven, especially in the last couple decades in medicine, that the nervous system that we get from birth is the nervous system that we'll have in perpetuity, that our nervous system, our nerves, our spinal cord, our brains can't change. What we've discovered in the last couple decades is that actually our nervous system is quite plastic and malleable, and that based on the way we move our bodies, based on even the foods that we eat, and especially based on our mindset, our brains can quite literally change. And there's a saying that's often said, neurons that fire together, wire together. And basically, if you repeat the same pain-relieving technique over and over, you can quite literally retrain your brain to expect that that is the norm. But in order to understand this neuroplasticity, we're going to have to go back to this concept of what is pain and why are we feeling it. Pain is an ancient alarm system. It's really deeply tied into the emotional, the limbic parts of our brain. Pain is an ancient alarm system that tells us something is wrong, something is dangerous. Those ancient alarm systems are able to be activated in many ways. Certainly in our evolutionary history, if we were being chased by our saber-toothed tiger, those alarm systems would turn on. And of course, if that tiger caught us, we'd feel more pain if they bit us. However, just the sight of that saber-toothed tiger is enough to turn on some of these systems, these alarm systems, to say, I need to retreat, something bad is about to happen. To take it a step further and bring us into our modern world, in a very real way, we have sort of Stone Age genes in a computer age world. Our brains, very complex, but still very primitive in many ways, can't quite tell the difference between that saber-toothed tiger and a boss that's yelling at us, or a deadline that we feel we won't be able to accomplish, or a spouse that has contempt for us, or kids who don't listen to us, or on and on and on, right? All the stressors and challenges of modern day life, those are all able to turn on those same mechanisms, those same alarm-based mechanisms that maybe that saber-toothed tiger would have turned on 25,000 years ago. Now, what's also important to understand is, though we can't always change those factors in our lives, you can't change the boss, you can't change the deadline, certainly can't change your teenager's perspective on what they need to do in their life. What you can do, though, is change your response to those things, and we're going to get into some of that in a little bit. But it's important to understand that if we do that often enough and effectively enough, we have the ability to quite literally change our brains. Based on that structural model, this is not a concept that's really discussed. Most of the patients who come in have never heard of this idea. It doesn't matter whether you call it neuroplasticity or plasticity or just the ability to change. What's important is that you buy into this idea that your mind and your body have the capacity for effective change. So one of the tools that I use actually in my clinical practice is clinical hypnotherapy. And people hear that and they think of stage hypnosis and someone getting on stage and clucking like a chicken. And it's really not that. And people undergoing hypnosis are always in control. And people undergoing hypnosis really are in just a physically relaxed, but also mentally alert state that's more open to suggestion to the subconscious mind. And so we have our conscious part of our mind, the part of my mind that's telling me, what to say and is aware of my surroundings right now. And then really just under the surface, most of our brain is actually firing in a subconscious way. And there are parts of our brain, especially our emotional centers, that are really painting and sending signals to the rest of our world that require us to cultivate and to send the appropriate signals to, so that we can get ourselves out of pain. And so on the screen, you're seeing a couple. We don't need to get again into a lot of this vocabulary lesson, a lot of the neurobiology, but these 4 areas of the brain. The somatosensory cortex is where you saw that homunculus, that guy who had, neck pain in one area and eye pain in the other. Really, that part of the brain is concerned with, well, where is my pain? How severe is it? And what is my opportunity to create an internal locus of control as opposed to an external locus of control? Very importantly, though, is the top left over here, the anterior cingulate cortex. This is the part of the brain that's activated when we understand that, yes, there's maybe pain in our back or in our eye or in our knee. But the suffering that results from that physical sensation of pain, the vast majority of suffering, that's actually really housed in this ACC in this area. Put another way, this part of our brain senses something is wrong and reframes it as, well, I need to do something about that. I need to fix that. There's something that I need to do. And unfortunately, with chronic pain, that becomes very difficult. And that process sort of perpetuates itself, and the suffering that we experience as a result of the pain, not being able to get rid of it as effectively as we'd like, really activates this ACC and turns this acute pain into a more chronic situation. The prefrontal cortex, that's the part of the brain, if you remember that word catastrophizing, that's the part of the brain that really tries to make sense of what we're feeling, really tries to apply some form of meaning. Well, why is this happening to me? And what does it mean for my future? This prefrontal cortex, based on some of the conversations that we have with ourselves, can really be turned on or turned off in some pretty effective ways. Now, the prefrontal cortex is also involved in rational decision making and planning for the future. And what we often find is that patients dealing with chronic pain have a very difficult time doing those types of things. That executive function part of our brain is not as effective as it needs to be, which again just perpetuates this issue. On the bottom right, just very briefly, the anterior insula, that's the part of our body and our brain that really is sort of taking stock of everything, and it's almost like our internal thermostat. It's trying to assess whether there's any damage anywhere, whether we feel whole, whether we feel safe. Signals from our organs, but also from our joints, come up to this insula. And all four of these areas talk to each other. And they also talk to another fifth part of the brain that we haven't spoken about very much, sort of an almond-shaped part of the brain called the amygdala. And the amygdala is really the fear center of our brain. And if that fear center is activated, all of these other centers are activated as well. And again, it makes that top-down conversation, brain to body, a little bit more difficult to have. And so going back to the same issue of the same image of these two knees, we're going to transition now into talking a little bit more about what it takes to actually become pain-proof. And that can be broken down into two sections. One is in terms of assessment, and the other is in terms of what we can do in some of our therapeutics and our modalities that can be effective for that. So in terms of assessment, of course, everything that we do needs to be personalized for the person sitting in front of us, and that always starts with a thorough history. It always starts with a thorough physical exam of the musculoskeletal system, of the joints, of the muscles, of the bones, and the alignment. But also it needs to take into account a very thorough neurological exam, which we're going to talk about in a moment. All of the doctors at InnerSource Health, myself included, are also trained in traditional Chinese medicine, which includes things like pulse diagnosis and tongue diagnosis, which can give us a better understanding of the internal milieu of people's lives. Similarly, there are some blood tests that can be useful, a standard CBC and CMP to look at things like organ function and blood counts and things like that. We can look at inflammation and whether we have certain nutrients that might be deficient. We can look to see if there are any autoimmune triggers, if our immune system might be overactive and that's what's causing our pain. And then for some people, we have to go a little bit deeper where we do more advanced testing. These days, we can do genomic testing, looking at people's DNA to understand, well, what is it about their heredity? What is it that they got from mom and dad that's actually increasing the likelihood, increasing their susceptibility of feeling this way? We can also do some pretty advanced testing around gut function and digestive function. And what we're learning, especially in the last couple of decades, is that how we feel in our gut certainly impacts the rest of our body. If we have inflammation, if we don't have the right microbiome, this is something that naturopathic doctors have been talking about for many decades. And the research and the science is now catching up in full steam. Finally, we have to look at hormone assessment and environmental assessments. Well, have we been exposed to anything, things like Lyme disease and mold? Are our hormones deficient or excess in a way that might be contributing? For example, if our cortisol is either too high or too low, cortisol being our main stress hormone, that same hormone that would get kicked into gear if we were running away from that saber-toothed tiger, it's possible that if our hormones are not where they need to be, it primes us to feel more pain. And so a thorough assessment will look at all of these things. I mentioned this idea of a neurological assessment. I'm just going to spend another moment talking about some of the brain changes that have gone on, and a thorough neurological assessment will actually look at a balance between the right and left sides of our brain in terms of our frontal lobes, our cerebellum, and our vestibular system. So our frontal lobe is involved in things like motor function. It's involved in memory, but also planning. It reduces our likelihood to be impulsive. Our cerebellum is really involved in regulating that motor function and coordinating things like balance and posture. And finally, our vestibular system, it's a part of our inner ear, actually, that really is involved in our sense of balance and our sense of spatial orientation, sort of understanding where we are in space. And so all three of these areas, if they're not functioning properly, and especially if either the left side or the brain side has become dominant in one of these areas, it can actually make all of our pain conditions worse. And again, based on that idea of turning your head to the left, well, it's possible that it's not actually the joint that hurt and why your body stopped at 18 degrees when 20 degrees is what would have caused pain in the past. But actually, it's possible that the brain is perceiving some form of danger because these parts of the body, these parts of the mind that are coordinating movement are sensing that something is wrong, are sensing an error, and it activates some of those other brain regions that we talked about. So a thorough pain assessment will take into account some of these brain-based and movement-based techniques. We talked about some of this. We're going to talk about some of these nutrient deficiencies and frankly, some of the benefits of the nutrients themselves in helping people deal with pain. We, from an environmental perspective, I mentioned this idea that it's important sometimes to test for things like Lyme disease or exposure to heavy metals or chemicals in our environment or molds. When it comes to gut function, we can do a lot, and we do a lot of microbiome testing to understand if we have the right bacterial flora, if there's any overgrowth of any yeast or parasites, to see if there's inflammation going on in our bodies. Most chronic diseases have at their core some level of inflammation. Well, it's possible that inflammation actually is coming from the digestive tract and is having an effect in other areas, like in our joints. Rheumatoid arthritis is a really good example of that. There's a lot of gut work that needs to be done to reduce the inflammation of rheumatoid arthritis. Similarly, if our digestive tract is too permeable, if different substances are getting through more than they should be, we're much more likely to experience systemic inflammation and immune system activation. And again, especially true for a lot of those autoimmune type diseases. And then finally, if we eat food and we can't break it down and absorb it very effectively, well, we might end up with some of these nutrient deficiencies on the top left that can predispose us to chronic pain. And that actually creates a little bit of a vicious cycle because, for example, if we don't have enough omega-3s, if we don't have enough anti-inflammatory fats and we're not getting them through food and then we're not absorbing them, well, that makes inflammation and a lot of these other factors worse. And then finally, we can do a 3-hour talk just on the genetics of pain, but there are some genes, and we're learning more every year, I'd say actually every 2 months, about some genes that are important. And it's really helpful to understand and personalize treatment around, well, what's someone's likelihood of having chronic pain after surgery, or what's their likelihood of developing an addiction to opioids or dependence to opioids, or vice versa. What's the likelihood that the opioid that they take is actually going to be effective for them? And that's based on a lot of things. It's based on the receptors for the medications, but it's also based on how quickly our body detoxifies a lot of these substances through our liver. And so that is all something that we can assess and something that we regularly do assess for people dealing with pain who are getting medications, but even for those who aren't, who would like to dig a little bit deeper. On the therapeutic side of things, we've got a pretty vast toolkit, and I'm going to go through these pretty quickly because we are a little bit low on time. But what's important to understand is that whatever therapeutic modalities are used for a patient, they need to be personalized to their individual experience. So whether it's nutrition, and we look at very specific diet or targeted nutrients for a patient, or it's mind-body techniques. There's a lot that we can do in the world of mind-body medicine. I mentioned this idea of hypnotherapy. Biofeedback has been shown to be quite effective for pain. There are certain brain training techniques and mindfulness techniques, which we'll talk about in a moment. But even the value of self-expression and creating a space where we can work through some of our emotional scars and emotional traumas can be helpful. Based on some of the testing, we might recommend some treatments around digestive health. Similarly, based on some of the assessments around the movement mechanics and some of those brain-based and neurological-based assessments that we did earlier, we might recommend specific exercises that have to be done safely. We might assess someone's posture or their gait, how they walk, and see if that's actually contributing to their pain any more than it needs to be. Similarly, there are some manual therapies, more physical therapies that can be quite effective in sending both that bottom-up signal and also a top-down signal from body to brain and brain to body. And so acupuncture falls very squarely in the middle of all these techniques. It's a beautiful technique that's been shown to be quite effective, and it affects both body and brain. It's actually been shown to quite literally change the brain for people with chronic pain. Similarly, we work on things like muscle, and we have other tools like taping and cupping and gua sha, which is an ancient treatment approach in Chinese medicine, the use of water, hydrotherapy. And then with a lot of these techniques, we can actually add electrical stimulation to those. And so one that's commonly been seen is TENS. TENS units are pretty effective at reducing pain in the moment, but they don't do a very good job of actually healing the pain. And so that's, again, where we have to take a both bottom-up and top-down approach. Similarly, people are really interested in the use of botanical medicines and herbs for dealing with pain and inflammation. And there are some treatments that are systemic, so they affect inflammation in the whole body, and then others that have to be applied topically. If you have a joint that hurts, you can actually apply some herbal therapies or some liniments topically. If we find on genetic testing that there's something wrong or something that needs to be fixed, then absolutely we add nutrients and cofactors and other types of supports that might turn on the good genes and turn off the bad genes. Similarly, if based on our lab testing, we see that the immune system is overactive, and we won't get too deeply into what Th1 and Th2 balance is, but basically sometimes in a body with the right susceptibilities, our immune system can get primed to sort of attack itself. And that's, again, what autoimmune conditions are, things like rheumatoid arthritis, which is the example we keep using. And so we can actually retrain the immune system to be less reactive. Similarly, sleep in a very real way is medicine, and then addressing some of those environmental concerns that we had touched upon earlier. What's important is finding the right technique for the right person at the right time, and that can evolve even within a person's personal history. And so if we break down some of the treatments that we're going to be looking at, this really is broken down into sort of foundational recommendations, things that work for chronic pain in general. Very often those are those top-down techniques. And then we look at some condition-specific recommendations. Well, what does the research say about migraines or recovery after surgery, or in the example that we're going to use, osteoarthritis? And so we're going to talk a little bit about some of the research-based ways from the natural medicine toolkit to actually address OA or osteoarthritis. So in terms of the foundational changes that everyone needs to consider when it comes to chronic pain, it's important to understand that the ecology and the sort of the ecosystem within which people experience their pain, their environment within which people experience their pain, is very likely to impact how much they perceive that pain. The reason you see a red and a blue light bulb, there was a study done by Dr. Mosley in 2007 and his team out in Australia that looked at the role that certain environmental cues can have on the likelihood that a person experiences pain. And they developed this pretty ingenious study where they used red and blue lights, and they used a probe that was attached to people's skin, and it caused a little bit of pain. But interestingly, the probe was always the same temperature. And so the way they were expecting to cause a little bit of pain was through temperature changes. However, for some of the patients, they applied a red light around that probe, and for some patients, they applied a blue light around that probe. And in general, based on some of those fear mechanisms we talked about, our brains perceive red as more likely to be dangerous for us because what we perceive red as being hot, and cold or blue is less likely to be dangerous for us. And what the researchers found was that anytime the probe was attached pretty consistently to a red light, they were more likely to experience higher levels of pain than they were if it was a blue light. And to bring that into more of a real world scenario, there's this idea, and I actually have some of my patients who are dealing with chronic pain really take this home with them. There's this challenge that when we go home and we see our loved ones and they see us suffering and they want us to get better, they offer to help us. And sometimes that can come in the form of a back rub, or helping out with something around the house, or honestly just listening and offering some words of sympathy. And of course, that all sounds great. How can I demonize that? But what we find very often is that those same people, every time they're around their spouse who gives them a back rub every time they have pain, tend to experience more pain around that spouse. And so with some of our patients, we've actually got this rule that they're only allowed to talk about their pain during treatments and not at home. And very often our brains tend to tone down some of that experience around their loved ones when that happens. That's a very specific example, but it does point very strongly to the role that context plays when it comes to discomfort. Much the same, when we feel like we don't have the support we need in our lives, when we feel like we're lonely or isolated, the same parts of our brain that we mentioned earlier, this ACC, this insula, this prefrontal cortex, you don't have to remember all of them. What's important to remember is that our brains perceive social pain as much as they perceive physical pain. And so if you're at a party and someone's ignoring you or excluding you, the same parts of your brain light up as if that person just punched you in the shoulder. And so we really need to pay attention to making sure that everyone dealing with pain gets the support that they need. And if you're listening to this webinar and you have a personal history of feeling isolated and feeling like you're unsupported, it's important to understand that you are not alone in this experience, and that there are support groups, there are people who understand, very often don't talk about their condition, and that it's important to express how you're feeling in those moments. That can go a very long way in this experience. Again, talking about some of the top-down approach, there's some really interesting research about the role that mindfulness plays in pain. And what we understand is that it's possible to retrain our brains out of what's called the default mode. The default mode is the part of our brain that's trying to make sense of the world, and it's piecing together the story of our lives, but very often it's focusing on the past, or it's looking into the future. It's very rarely allowing us to actually be in the present moment. And mindfulness training, following your breath or following a mantra, what it literally does is it retrains our brain to get out of that default mode, which has been associated with more likelihood of chronic pain, and it brings us back into the present moment, where it's much more difficult to experience pain if we're focusing again on our breath, or on a specific mantra, or even on certain body sensations, depending on the type of meditation practice that we undergo. And put another way, based on some of these concepts, we mentioned this idea of a top-down approach. There are really two components to building resilience around mindfulness, and they involve reaching toward our joy, or finding the things in our lives, even within the context of our disabilities with pain, that we can still enjoy. They need not be huge things, and they need not be the types of things that we enjoyed in the past, but really taking stock of what gives us joy today and focusing in on those is important. But just as important is not just thinking about those things, but remembering how those things made us feel. Our bodies are feeling organs. Quite literally, the system is built around sense perception and not thought perception. If we can come into our bodies, which we often neglect when we're experiencing chronic pain, and really feel what we're feeling when we're experiencing that joy, in a very paradoxical way, it actually brings down some of those pain mechanisms. And so we'll go through this very quickly. There's really strong research in what's called the systematic review and meta-analysis that these types of approaches are an effective approach to pain care. They need not be delivered only through mental health providers and things like that. They're important. They don't mean, and it's important to reiterate again, that the pain you're experiencing is only in your brain, but it is important to take that top-down approach and to allow the brain to send a signal back to the body that we're safe. Similarly, mindfulness has been shown to be quite effective for pain. And a lot of these things are fairly esoteric. We've always heard this idea, especially in the last decade and a half, that meditation is interesting, and we think of these yogis or gurus that quite often we imagine them sort of levitating over a pillow and having this out-of-body experience. Well, it's absolutely not necessary to have that experience. Just the act of sitting and focusing in on some kind of anchor, our breath, again, a mantra, is just enough to change our body, to change our nervous system based on that idea of neuroplasticity, to change our physiology in a way that can have downstream effects. And to take it a step further, we can actually measure this. So there's an idea called heart rate variability, which is a function of how a certain part of our nervous system called the autonomic nervous system, which really is composed of two aspects. There's the sympathetic part of our nervous system that is activated when we were running away from that saber-tooth tiger that we spoke about earlier. And there's the parasympathetic part of our nervous system, which is the more relaxing, also called the rest and digest part of our system. And what we find is that these two parts of our nervous system are sort of always at odds with each other. And the more healthy they are, and the better the communication is between our body and our brain, and vice versa, the higher the level of something called heart rate variability is. And so all those yogis and gurus that we imagine, if we measured their heart rate variability, it would be quite high. What's interesting is that certain thought patterns and certain breath patterns can actually increase our heart rate variability and improve what's called coherence, make the changes between those two parts of the nervous system much more smooth and adaptive. And so if someone's feeling anger or frustration, they don't have a lot of heart rate variability, not a lot of range, but also if you're seeing the screen here, it's quite jagged. Whereas if someone's feeling appreciation or gratitude, it's one of the techniques that's always been shown to be quite effective in changing heart rate variability. We see a nice, gentle, sine wave-like pattern with a lot of depth and also with very smooth transitions. That is a sign of a healthy autonomic nervous system sending signals of safety from body to brain. And that, again, signal of safety turns down some of those alarm mechanisms. Similarly, people who don't sleep very well tend to have a higher chance of chronic pain. It's been estimated that up to 88% of people who deal with long-term pain also have trouble sleeping. And in very real ways, trouble sleeping perpetuates pain, and it becomes a little bit of a vicious cycle, and it's sometimes hard to distinguish which came first. Poor sleep impacts our ability to process opioids, which are those natural painkillers, to produce the right levels of certain neurotransmitters like serotonin, which is deeply involved in things like sleep and mood. Poor sleep impacts our immune function. It impacts our stress response system, and it impacts something called the endocannabinoid system, which again, we can do another couple-hour lecture on, but that's the part of our body that's getting a lot of research now that people are interested in things like CBD as a pain reliever, CBD being the component of marijuana that's been popularized, especially in the last couple of years. In terms of sleep, what our bodies really need to sleep effectively are regularity, the right form of light exposure, which often is no exposure to light at all, the right temperature, making sure that we don't get too much of the wrong fluids, and that our stress response is not impacting our sleep. So let's just talk about each of those briefly. So our bodies do very well with consistency. If we go to bed at the same time and wake up at the same time, that's probably the best indicator we have of allowing ourselves to move into the types of deep sleep that we need. Slow wave sleep is the part of sleep that impacts our physical body, and REM sleep is the type of sleep that impacts our brain, though of course they impact both systems. If we have to separate them, that's a fairly accurate estimate. And sleep consistency, again, going to bed at the same time and waking up at the same time impacts both of these things. Similarly, our bodies are not used to sleeping with lights that are available and around for 24 hours a day. Really sleeping in a pitch black room is very important. In terms of temperature, cooler is generally better. What we find is that for the body to initiate sleep, to get into deeper stages of sleep, our core body temperature needs to actually fall about 2 to 3 degrees. And so one way to do that is to make the room cooler. Another way to do that is to drink a hot beverage. That's why some people like herbal teas before bed, or to take a hot shower before bed. That actually primes us to increase our temperature so that it can drop as it transitions into sleep. Some people really do have trouble with drinking coffee. I have some of my patients who shouldn't drink any coffee at all based on how long it takes them to process the caffeine in their coffee. Similarly, people who drink alcohol before bed, alcohol is probably one of the worst things we can do to affect that deep sleep, that REM sleep. And so in people who are susceptible, it's worth considering not doing that, especially if they deal with pain. Drinking fluids too late before bed, really I have some of my patients who struggle with this, stop about 2.5 to 3 hours before bed, and that can help. And then not thinking about stressful things, which is often hard in our modern world, not watching the news, not watching horror movies or Netflix shows, or Stranger Things or whatever you're watching on TV, is important because, again, our bodies can't quite tell the difference between watching that on TV and running away from a saber-toothed tiger. And so it activates the same stress response that makes it difficult to sleep, and it becomes a vicious cycle on its own. And for all of these reasons, having an appropriate routine before bed, a routine that takes advantage and takes account of all of these sleep hygiene tools, is one of the first steps. And I'd say 40 or 50% of the time in people who are sleeping poorly, if we address these things, they don't need any supplement or any kind of medication. We can get them feeling better. And just the same, before we try any kind of supplement or medication, we need to make sure the sleep hygiene is appropriate to know what type of sleep issue they actually have, because very often these challenges can mask the actual sleep issue going on. We've been talking a lot about the role of feeling empowered and taking care of ourselves and taking care of our pain. And put another way, self-management of our pain, this idea that there are steps that we can take to help ourselves feel better, has actually been shown, has been validated as a useful approach, not just to help people feel more confident about their ability to do so, but actually to help people reduce the severity of their pain. And so in one study, a 6-week program that looked at a little bit over 300 patients, where they were taught self-management techniques around things like proper movement and sleep and nutrition, actually reduced their severity of sleep, how much it interfered with, or severity of pain, how much it interfered with their lives, and how much it actually caused them to feel disabled in their lives. And similarly, and very importantly, it impacted things like anxiety, depression, and sleep. So this was just an online program that taught people some very simple self-management tips that were pain-focused. And just through education, we're able to activate some of those same brain regions that turn down the pain while allowing them to make some of the lifestyle changes that help the body send the right signal back up to that same brain. We mentioned earlier this idea that things that had happened in our past can certainly affect our likelihood of dealing with pain and can prime our brain to experience those alarm mechanisms more readily. Most of the research that we have confirms that when people have early childhood trauma, they're much more likely to be in pain. And we have some studies where people were followed for decades, from when they were 7 years old, assessing the amount of trauma they were exposed to then, until they were in their 50s and 60s. And pretty consistently, higher levels of childhood trauma can contribute to pain. And so if that hasn't been something that you've resolved in your life, or you haven't worked with someone to resolve that, it's important to do so, because the pain treatments that you're getting, whether it's medication or physical therapy, might be made more effective if you are able to effectively process that trauma and reintegrate some of those experiences back into your life. And there was a study that was done based on a technique called emotional awareness and expression therapy, that they compared group self-expression. So the intention being creating a space where people can express how they feel and express things that happened to them in the past, but also express how they're feeling in the moment about their pain. People who underwent this form of treatment, who had a specific condition called fibromyalgia, which is often a very difficult chronic pain condition to treat, tended to do better than people who just got education about fibromyalgia, but also better than people who got cognitive behavioral therapy, which has historically been the gold standard psychological therapy for chronic pain. But interestingly, people who did this emotional awareness and expression therapy were more likely to have at least 50% pain reduction than the CBT group. Across all other measures, they were pretty equal in their effectiveness, but just this opportunity to express yourself can have a pretty powerful effect on pain. Not everyone has access to these types of groups, but even something as simple as journaling can certainly increase the speed with which you recover through pain. Very often that journaling should be done with some guidance of someone who can help you navigate what's appropriate and what's not, and the timing of when to express the things that are most troubling and when it's safe to do so. In terms of exercise, again, another 3-hour lecture on that I've given, but the first question becomes, is it safe to exercise when you deal with chronic pain? We mentioned earlier, with acute pain, with an injury that's just happened, you may actually not want to exercise, but get back to it as soon as you can, as soon as that acute stage of pain comes down. When it comes to chronic pain, probably it is safe. It's probably unlikely that you're going to be causing any kind of additional harm to your body by exercising. Just because something hurts doesn't mean it's continuing to harm you. But of course, make sure you talk to your doctor and get a thorough assessment before you start any kind of exercise routine. What's important, though, is proper pacing. Very often what can happen is people dealing with chronic pain will either not move at all, which has its own challenges that we've discussed, or they'll completely overdo it. And one day they will be feeling better, and so they'll try to clean their whole house. And the next day they just feel terrible. And so what happens is pacing appropriately and gradually increasing the amount of exertion that you're undergoing, whether it's classic exercise like walking on a treadmill or literally just cleaning your house or doing chores, pacing is appropriate. And so one of the best techniques through self-management education is to find the level of activity that you can safely do without exacerbating your pain in the next 24 hours. Cut down to about 80% of that, and then increase by 5% each week. And so as a pretty easy example, if you figure out that you can walk 5,000 steps a day without causing any pain, but 6,000 causes pain, you reduce that 5,000 to about 4,000. So you do about 80% of that. And then every week you increase by 5%. Over the course of a month or two, you might be up to that 6,000. Then you continue to pace up from that perspective. That's a far more sustainable approach to helping you feel better when it comes to doing exercise that doesn't overdo it and doesn't exacerbate your condition. Similarly, it's not just whether we exercise or not. It's not binary like that. It's also what our posture looks like and what our gait looks like when we walk, and how we sit, and how our body is positioned when we're doing things like work and even sleep. And so having an assessment, very often companies these days have ergonomics departments where you can actually have someone come to your desk and adjust your monitor and adjust your chair to make sure that you're not continually exacerbating yourself. So if you do work, especially in an office setting, it might be worth seeing if you have those resources available to you. But certainly having an expert assess the way your body moves and the mechanics of your movement and your posture is very important in making sure both that your exercise is safe, but also that even when you're not exercising, you're not making your condition worse. Similarly, if you do go to the gym or if you go exercise, in the beginning, it might be helpful to have a trainer who can understand whether you're using the right form to not make yourself feel worse. Switching gears a little bit, we mentioned this idea of the benefits of electric stimulation. Certainly when it comes to acupuncture, what's called electroacupuncture, or adding electric stimulation to the acupuncture needle, can be quite effective and can actually make the treatment more effective. It turns on our body's production of natural painkillers a little bit more effectively. Similarly, there's a device called a TENS unit that people have been using for a long time now. TENS units are pretty interesting in that they're pretty affordable. People can take them home with them. They can order them online for 20 or 30 bucks sometimes. And what they do is they allow you to get yourself out of pain very often in the moment. They're not actually healing any of the tissue damage, and they're certainly not sending a signal to the brain to say that things are safer, but they do help you feel better while they're on. And so sometimes 30 minutes, 3 times a day. I've had patients who wear them, for 12 hours out of the day, because it does bring relief in the moment when you're wearing them. There's a new technology called PEMF. It has been around for a while, but it's not as popular. There's some interesting research that shows that actually does create some longer term healing. And so that needs to be explored a little bit further before we can say that for sure. I mentioned the idea of acupuncture. Acupuncture is very effective. It's been proven to be effective beyond placebo. And importantly, its effects have been shown to last up to about a year based on the research, that the benefits and the pain relieving benefits are sustained. And because we've been talking about the complexity of something like chronic pain, it's also nice to see that acupuncture can affect things like anxiety, depression, and even digestive issues and gut function. And so it's a really useful modality and useful tool across the board. Of course, it's important to understand that the way we eat and the food we put into our bodies can have a lasting impact on how we feel. And there's some really strong research, actually a review that came out just in April of this year that looked at a combination of 23 studies that confirmed something that NDs have known for quite a long time, confirmed that nutrition has a pretty strong impact on chronic pain. Now, there are a lot of approaches to nutrition. That's why we call this slide food as medicine, because it's not just that everyone should be on a dairy-free diet or everyone should demonize gluten or everyone should eat what's pretty severe and restrictive called an autoimmune paleo diet. But what's important is that we find the approach, the food plan that is actually conducive to you feeling well as an individual. One of the ways to figure that out is to go through something called an elimination diet, to systematically remove certain foods that are most likely to be inflammatory or most likely to increase your experience of pain, and then to systematically, with the help of a healthcare provider, reintroduce them one at a time to make sure that the foods you're eating aren't making you feel worse. Similarly, there are some really important nutrients that can increase your pain if they're deficient, or decrease your pain if you have enough on board. We'll talk about omega-3s in a little bit as we talk about osteoarthritis. Vitamin D is a really good example. Pretty much across the board, what we find in the research is that when people are deficient, their likelihood of having chronic pain goes up. It's especially true in autoimmune type conditions. We keep using rheumatoid arthritis as the example of that autoimmune condition, where the immune system is in some ways attacking the joints. What we find, though, is that when people are supplemented with vitamin D and their levels get to the right level, that response is diminished and the immune system learns to be less reactive. And interestingly, people, talking about genetics, people with certain receptor mutations in their vitamin D receptor have a higher risk of rheumatoid arthritis because the vitamin D is not as effective as it could be in retraining that immune system. Getting enough magnesium is important. Magnesium is really important in muscle relaxation. And very often what happens with chronic pain is that our muscles tense up, and that's actually what's exacerbating and perpetuating our pain. B vitamins are important for making sure we make enough neurotransmitters to improve things like mood and some of those other brain responses that we spoke about. So switching gears, and we'll go through this pretty quickly because we are running out of time. Beyond some of those foundational recommendations, beyond the thorough assessment that takes into account both a top-down and bottom-up approach, we can also look at specific conditions. And that's really where this medicine shines, is that it's very much personalized for the patient. And any condition that we treat has to take into account, like we've been saying, that bottom-up and top-down approach. And so we can actually plot what some of the treatments might be that might be useful. And so for a patient coming in with osteoarthritis, well, they might be getting acupuncture, and they might be changing their diet, and they might be learning how to exercise differently, and they might be getting soft tissue work. And some of those treatments are really effective for the body. And some of those treatments are really mostly effective for the brain, but not that much of an effect on the body. And so we have to make sure that we have a nice sampling of all of those so that the treatment is comprehensive and that it's truly biopsychosocial, to use that word again. And so in terms of what the research shows as far as what's important and useful for osteoarthritis, we can't talk about every condition because there's so much to cover here. We'd have to do, a couple of hours on every condition, but we can do a quick survey of osteoarthritis to show you, what can we feel confident in saying, hey, this stuff actually works, or what's just marketing, overblown marketing that people are trying to make a quick buck. And so when it comes to osteoarthritis, one of the first things we have to do is help people lose weight. Now, that needs to be done in an effective and in a sustainable way. However, what we understand is when it comes to osteoarthritis of the knee, where, remember, we talked about the possibility that people are sort of bone on bone and they're more likely to have pain. For every pound of weight that we lose, it takes about 4 pounds of pressure off of the knees. And so, losing 20 pounds right away can reverse osteoarthritis without any of these other modalities and any of these other treatments being necessary. There are some herbal remedies that are useful. And in general, when we study a lot of these remedies, beyond looking at what their mechanism is, we also want to understand, well, how effective are they to the standard of care, to the other types of treatments that might be available for people? And then what is the safety profile in comparison to that standard of care? And so very often when it comes to arthritis, the standard of care is just giving people what are called non-steroidal anti-inflammatories, things like ibuprofen, Advil, naproxen, whatever it is that you're taking. And so we often want to compare these quote unquote natural therapies to some of these other modalities. And if the safety profile is stronger, and if it's proven to be safer for longer, then it's certainly beneficial to take the quote unquote natural thing as opposed to the over-the-counter medication, that can cause things like abdominal pain or abdominal bleeding. And that's the case with a lot of non-steroidal anti-inflammatories. They can be quite dangerous if taken in high supply. Same thing with Tylenol, which is another pain reliever. It can be pretty toxic for the liver, can cause a lot of other damage. And so when we have other tools, we really should be using them. Curcumin is one of the best studied ones. Curcumin has some anti-inflammatory properties. It reduces oxidation, and it actually helps to rebuild and recover the cartilage in our joints. And after even 4 weeks of treatment, turmeric or curcumin or standardized extracts of that have been shown to be as effective as ibuprofen, again with a better safety profile. The same can be said about omega-3s. In general, if there's inflammation in the body, we're more likely to feel pain. And in general, if we are deficient in EPA and DHA, which are the two most important omega-3 fatty acids, which are commonly found in cold water fish, things like salmon, mackerel, herring, in general, if we can get those on board, the pain can reduce. And so at a pretty low dose, 1,000 milligrams of EPA and DHA combined, up to 2,000 milligrams, both pretty low doses, we see benefits in people with knee osteoarthritis. Bromelain has been commonly studied. Bromelain is an enzyme that's actually found very often in pineapple, and it was compared to diclofenac sodium, which is a common painkiller, and it was shown to be just as effective after 16 weeks of treatment. Again, with a better safety profile, bromelain can have a little bit of a blood thinning effect, as can a lot of these anti-inflammatories, so you want to be careful with that, of course. There's a component of both avocado and soybeans that's called unsaponifiables, which basically means it's about the 1% of these, of the avocado and the soybean that can't be turned into soap, of all things. And interestingly, those components have actually been shown to be quite effective and sometimes more effective than those non-steroidal anti-inflammatories in reducing osteoarthritis of the knee, and actually more effective than chondroitin, which is a common supplement. Interestingly, though, when it comes to hip osteoarthritis, these ASUs actually might be effective in not just reducing the pain, but in sustaining the structure. And so in one study, 20% of people had less joint damage over the 3 years of the study than people who were just taking a sugar pill or a placebo. So that's interesting. It's something that certainly needs more study, but it's one tool in the toolkit that we might be able to take advantage of. Similarly, red pepper, capsaicin, we mentioned that some of the herbs or botanicals that we use should be systemically used and can internally reduce inflammation and swelling and pain, and some do better topically. Standardized extracts of capsaicin, which is the component of red pepper that can have some of that burning quality, have been shown to be pretty effective in mild or even moderate osteoarthritis of the knee compared to placebo. And that includes reduction in pain, reduction in actual stiffness, and the ability to move and to function overall. And so capsaicin is an interesting modality. It can be quite effective. Of course, you have to be aware of that burning sensation. Most people, though, it is pretty common. About 60 or 70% of people will feel that, but it won't necessarily stop them from the treatment, especially, of course, if it's reducing their pain. Boswellia, commonly known as frankincense, has something called boswellic acids, which have been shown to be pretty effective. In this one study, just over 300 milligrams taken 3 times a day was shown to improve osteoarthritis of the knee and people's ability to walk and flex their knee effectively. So it gives better range of motion and it reduces pain. Glucosamine and chondroitin may be the most common supplements used for osteoarthritis. There was a pretty strong meta-analysis that looked at a combination of 26 studies, studies through May of 2018. And basically what they concluded was that chondroitin is effective in reducing pain. Glucosamine is effective in reducing stiffness. Of course, it's not right for everyone to take it. We shouldn't just be putting it in the water. But in the context of a personalized care plan that includes everything else that we talked about, some of those brain-based therapies, some of that top-down approach, this bottom-up approach to give the body what it needs to regenerate some of that cartilage might be effective. And so we've covered a lot. We've covered it quite quickly. We're probably over time at this point. Part of the challenge with a talk like this is it's such a big topic and we want to make sure to cover as much as possible and give as much value as possible, is that we can't get into some of the specifics for each individual. And so we'll take a couple of quick questions in just a moment. But if anyone has any questions based on their personal history or those of a loved one, if you go to drkachko.com/schedule, feel free to grab a free 10-minute discovery session. I'd be happy to hop on a call with you and explain a lot of what we talked about within the context of what's actually happening to you, which sometimes can make a lot of this make a little bit more sense based on what you've been experiencing personally. Again, thank you for bearing with us on this long evening. We're always posting at InnerSource Health on our blog and on our Facebook page, so make sure to follow InnerSource Health on Facebook, and then similarly follow me on Instagram and Facebook, Dr. Kachko or Dr. Kachko ND, and similarly InnerSource Health on both. So we've got a couple of minutes, maybe time for just 2 or 3 questions. Let's see what comes in. And you can submit your questions anonymously as well if you don't want your name shown. Okay, so one question came in when we were talking about acupuncture. Does acupuncture hurt? That's probably the most common question we get about acupuncture. Fortunately not. Sometimes you can feel a slight pinch, but it's never something that is uncomfortable to the point that you can't relax when the treatment's ongoing for the 25, 30, 40 minutes that you're getting it. Most of my patients end up falling asleep or feeling relaxed. And if anything's ever uncomfortable, you can certainly make that go away right away. And then the same person asked, how many treatments of acupuncture are usually necessary? That's a very individual and personalized question that usually after about 4 or 6 treatments, we can figure out what would be useful. Historically, if you're not feeling any relief by about 8 or 10 treatments, it's probably not going to work for you, but some people do need to go, double that to get the full benefit. In terms of how often people should be seen, some conditions require 2 or 3 times a week. Some are fine once a week. I have patients who end up coming in for whatever acute condition, ankle pain, and then they discover that, you know what, my ankle pain's better now, but also my stress response was better and my mood was better. And so they end up coming in for tune-ups once a month. So it really is personal based on that. So another question here about, we mentioned the elimination diet, sort of approaches to testing for food sensitivities. Yeah, that's a common question we get as well. There are a lot of direct-to-consumer tests out there. There are tests that are done through doctors that help you based on your blood work or based on your genetics, figure out what the perfect diet is for you or what foods you should avoid. And so the genetic stuff, there's some interesting things, lactose response, caffeine response, whether you should be doing coffee or not, that have some pretty strong research. Others, I think, are just a little bit before their time. When it comes to food allergy testing, though, very honestly, I don't see a lot of correlation to clinical symptoms. Very often what we'll get is a person who's reactive to like 80% of the foods that were tested. And that's not an issue with those 80% of foods. That's an issue with their gut function, with inflammation, with gut permeability. And once you heal that up, they're less reactive. Also, I don't know that most of the tests are very consistently reliable. And so I really trust elimination diets more effectively, where we're trusting the person's symptoms, though they're a little more difficult than just sending out a test. They're far more accurate from my perspective. And there's a lot of learning that goes on around the relationship we have with food as well. So yeah, there is one lab that we use that I'd be happy to explore with you if that's something that would be effective. I find that they're probably the most accurate, but otherwise I think an elimination test is the best bet for that. We'll take one more question, and then feel free to email me at drkachko, Dr. Kachko at innersourcehealth.com if you have any other questions. But this last question is, what's the role of hormones in terms of chronic pain? And that's a great question that we really didn't even have time to get into. Certainly people who are deficient in things like estrogen can have an activated pain response. We mentioned a little bit about cortisol function. Well, very clearly, if people have either high or low cortisol function, that means that their stress response is not effective and appropriate. And so there are things that we need to do to improve the cortisol response alongside treating the other pain-related stuff. While we understand that if someone's cortisol is too low, their ability to turn down their inflammation is just not as effective as it needs to be. And so we can actually try to do that alongside some of the more physical pain treatments. Things like thyroid hormone also play a role. Certainly, if your thyroid function is low, that can affect things like energy and mood. It can affect pain as well. And then that becomes sort of a self-perpetuating vicious cycle. And so getting someone's thyroid to be a little bit more effectively working is certainly a useful approach as well. So that's a good question. It does take a little more nuance understanding the full case to answer completely, but thank you for that question. All right, so I do see a couple of others coming in, but I will answer these. I'm seeing who they're coming in from, so I will answer them via email. Thank you everyone for bearing with us for this pretty long seminar, but hopefully you learned something new. And again, feel free to reach out either on the website or through email or through social media, and we'd be happy to answer any questions you have. You can also give us a call at 631-421-1848 to work with any of our InnerSource health providers. Thank you, everyone, and have a great day.